Good morning, everyone. For those of you who don't know me, my name is Pranati. I'm the virtual team member here at Health for the World. Thank you all for joining us today to hear about this very important topic of postpartum hemorrhage. Our speaker today is Dr. Mark Rollins. He's an MD, PhD from Mayo Clinic. Dr. Rollins is an anesthesiologist in the Department of Anesthesiology and Perioperative Medicine at Mayo Clinic. After completing a combined plastics and general surgery program at the University of Pittsburgh, Dr. Rollins went on to pursue anesthesiology and obstetric anesthesiology at the University of California, San Francisco. He has received numerous educational awards, including the William K. Hamilton Award for Excellence in Teaching, and is involved in many publications involving creating guidelines for obstetric anesthesiology used nationwide. We are very, very lucky to have him with us today and in conversation with him about postpartum hemorrhage. And so without further ado, Dr. Mark Rollins. Thank you.
Thank you so much. It's really an honor to be speaking again here. Right now I'm just trying to get my slides to advance. There we go. So as was already stated, today's topic is going to be postpartum hemorrhage. And in addition to being at the Mayo Clinic, I do serve on the American Society of Anesthesia's Committee on Obstetric Anesthesia. And I had the privilege while I was at UCSF for many years to help with their statewide effort to reduce maternal mortality from hemorrhage. And I have no disclosures. And so to give you a little bit of a roadmap where the talk is going to go today, we'll start out just sort of going over the degree of maternal mortality that's due to hemorrhage, resources that are available to you primarily from the web and the literature, and also then to finally go into considerations for developing protocols to help reduce maternal morbidity and mortality from hemorrhage, recognizing it, how to manage it, and so on. So on some of my slides, you will see a QR code. You're welcome to just use that, and it will bring you to the publication or the resource that I'm talking about. Here we have a recent publication from the World Health Organization, Trends in Maternal Mortality. And to begin with, we see that over this 20-year period, we have made reductions in maternal mortality, but we have a long way to go, right? So over those 20 years, maternal mortality dropped about 34%. To put it as a ratio, that went down from 342 to 223 maternal deaths per 100,000 live births. Okay, and that's worldwide. But that still means that here, after 2020, we still are at a rate of almost 800 women dying from preventable causes related to pregnancy and childbirth. Okay. Unfortunately, we see that about 95% of all those maternal deaths are occurring in low and lower middle income countries. And we have a variety of examples where we can demonstrate that care by skilled healthcare professionals during the peripartum period can indeed save the lives of these women. Okay. To give you sort of a little bit of a regional breakdown, when we look at the world map, we see that of those maternal mortality numbers, almost 87% are coming from sub-Saharan Africa and Southeast Asia. And that, is where a lot of the effort really needs to be concentrated. Obviously, these are areas where access to healthcare is quite limited, as are resources, but there's still plenty of room and resources available that I think with additional education, we can continue to reduce this mortality. Okay. To break it down a little bit more, you can see that the ratio of hemorrhage as a cause of maternal mortality really varies by parts of the world. Where again, if you look in developed countries, it's only 16% of the causes of maternal death. And in the US, it's closer to 11 or 12% currently. Whereas if you get into lower resource countries, it becomes a much larger component of the overall maternal death. Okay. So I want to step back a little bit and talk about the experience we had in California. And we use California. One of the reasons was because it's a very large state in the US. It represents about 1/7 of all births that occur in the United States. And what was done was back in the early 2000s, they took 2 years, they looked at data from all maternal deaths in that state over 2 years, and they looked at the causes of them in depth through the medical charts. And in doing so, they noticed that a lot of the issues were delayed response, ineffective care, misdiagnosis, lack of appropriate people taking care of the person. And so what was done was what they noticed when they went through these charts was that they felt that overall, all types of maternal death, about 40% could have been prevented with just better medical knowledge and preparation. And they looked at hemorrhage in specific to those types of maternal death in California. And they felt that 70% of those deaths could have been prevented just by better education, planning, and appropriate resources being in place. So that's what California went after first in the early 2000s. And in about 2008, they set up a task force that I was sort of privileged to be part of. They surveyed all the hospitals in the state and were trying to determine what was going on with them. And in about 173 of those 261 hospitals, they noted that 40% had no protocols for hemorrhage during childbirth. 70% were not engaged in any sort of ongoing drills or simulation. And a significant number didn't even have all the medications that were available in their hospital to treat postpartum hemorrhage and uterine atony. So what was done then was it was a statewide effort where we implemented these educational materials, taught more about what needed to be in place to reduce maternal mortality from hemorrhage. And we saw a significant drop in severe maternal mortality and morbidity by over 20% after those years where we intervened in about 126 hospitals in the state. And this was a significant reduction compared to the hospitals that didn't participate. Okay, so what this did was really strengthen our idea that it is possible to intervene and make a difference just with some minimal resources, training, and education. And that's what I want to impart to you today. So we have a QR code up at the top. If you scan that, it'll bring you to the most recent toolkit version that was part of the California effort. They just updated it about a year ago. And when I say toolkit, what it does is it gives you the resources for your healthcare location for things you may want to implement that you can strategize for what's going to work best at your location. Because obviously some things work better in some areas and some things work better in others, but it's just a set of tools to look at and resources. The next 3 slides are similar ideas. And if you were to forget this whole talk, this slide and the next 3 slides with those QR codes are really what you need for the resources to help reduce maternal death from hemorrhage. So another effort that recently came out following the California effort was a United States-wide effort for obstetric hemorrhage. It was an Alliance for Innovation on Maternal Health Care. There's a link to the resource bundles there. And then there's the World Health Organization, right? So they initially came out with 32 recommendations in 2012 for what they believe should be in place at all healthcare organizations worldwide that are taking care of birthing mothers, okay? And there were updates to those recommendations in 2017, 18, and 20 that I have placed within the talk as we go along. but that's another terrific resource. And then finally, in 2002, about a year ago, the International Federation of Gynecology and Obstetrics came out with their recommendations, which mirror a lot of the World Health Organization's recommendations for how to prevent mortality from postpartum hemorrhage. So those are the resources. I want to make sure those are available to you, and I recommend that you take a look at those in the future and think about what you could do at your healthcare location to implement some of these strategies. Okay, so the idea is that they use 4 R's, right? Readiness in every location, recognizing every patient that's in trouble, responding to every type of hemorrhage, and then reporting where everybody participates to try to improve within their own healthcare system. All right, so let's start with readiness. What does this mean? Well, these are some of the ideas that have been put out, and they are establishing a response team with multiple disciplines. So you can imagine OBGYN, labor nurses, anesthesiologists, internists, and so on. Having a location where all the equipment you need is readily available. So as an example, it would be a hemorrhage cart that has protocols and instructions, maybe in a binder or placed on it. So there's easy dissemination of knowledge and what to do in that crisis. And then rapid access to medications that would be used, such as various uterotonics, tranexamic acid, and so on. Having some sort of protocol for massive transfusion. Obviously, each place has completely different resources, but whatever resources you have, having some sort of plan for if someone is hemorrhaging, how can you mobilize those resources quickly and effectively? And then doing simulation. Ideally, these are relatively rare events, and so no one gets really good at them without simulation, but going over simulations of pretend hemorrhages and going over checklists to make sure all the little items were done so that when a real one does arrive, you're more likely to transmit effective care to that patient. Okay, so this is just an example of what you might want to have in a hemorrhage cart, from certain instruments to intrauterine balloons that we'll talk about, equipment to help get rid of retained products of conception, headlamps, certain trays, other surgical instruments, as well as a variety of medications to help tighten up the uterus following an example of uterine atony, some fluids, and so on. Okay. One of the other elements that we use is trying to figure out which patients are at most risk of deteriorating before they actually do. So this is an example of a modified early warning system. And what is done is periodically following delivery or even before, the patient is scored based on their vital signs and their mental status and urine output, and they're given a number from 1 to 3 for each one of these elements. Those numbers are added up, and the higher the score, the more likely you are for that patient to have a problem, and you may want to get more physicians there or keep a closer eye on them, more frequent vital signs, and so on, as you see they're at higher risk for deteriorating. Okay. And this is just an example of one institution where that was used, where they have like a little chart, and then they have dates and times for a given patient, and you can watch the scores in each one of these categories and keep the total and determine which patients you need to pay the most attention to. Okay. We have a little bit of evidence in the literature of a institution where both groups A and B got standard care, but group B, they implemented another example of an early warning system. And what they noticed was that they significantly decreased maternal morbidity just by implementing a system like this. So it's something that I, would recommend. Okay. This is an example of a flow chart. It's a bit busy, and I'm not saying you need to use this one, but just the idea of having some sort of plan from admission through delivery. If hemorrhage occurs, you grade the hemorrhage in different stages that you can see on the left, and then associated with it is what people should be doing at that time. The last part we had initially mentioned was, team training, simulation, running pretend hemorrhages or emergencies. And we do have some evidence that doing this within a given institution allows you to see areas that need improvement, improves education, and has been shown to reduce adverse outcomes in delivery. So those are some of the things that you can work to have in place at your institution. So now we get sort of into this recognition phase of when a hemorrhage is occurring. Okay, so the first thing to know is, what are some of the risks for postpartum hemorrhage? So we have a list of them here, and a lot of these are things that can lead to not just hemorrhage, but often uterine atony. And that and retained products are probably the two biggest reasons for postpartum hemorrhage. We talked about one risk assessment based on vital signs, but another one to think about is just the patient's history, right? And so you can see an example of a low, medium, and a high risk. And a low is, no prior surgeries have been done. It's just a single pregnancy, and there's no known bleeding disorders. And then as you increase in risk, you have more prior cesarean deliveries. Maybe there's an infection like corium neonitis, and then, or a history in that patient of bleeding on a prior delivery. And then you get into really high risk when you have laboratory abnormalities, low platelets, they're active bleeding. And again, these risks are not static. They can change categories as the labor goes on. So if they begin to have prolonged stages of labor, or you see bleeding even before the delivery, or the patient is preeclamptic with severe features and they end up being put on magnesium sulfate, then this is going to potentially increase their risks. Okay. I think I'm going to save, I just took a peek at the questions here. So I am going to save the questions for the end, and then we'll come back to them. But, feel free to continue to type them in as you're thinking about them, and then I'll leave time to address them. Another thing in the recognition is measurement of the blood loss. In obstetrics, blood loss can be very hard to quantify. It's often on the floor. It can be in the bedding and in sheets, in different pads and gauzes. So things that have been done. There are conical drapes available for vaginal deliveries that can help quantify blood loss, and other things that can be done are weight based, where the weight of the items that you're going to use ahead of time, and then you weigh them after they've been saturated with maternal blood, and then you can estimate blood loss that way. And these methods help improve the quantification of the blood loss, as opposed to just looking around and having a really gross estimate. And the reason that's important is you would like to identify women who are having abnormal amounts of bleeding early on, before they get into some sort of extremis. All right. Do we have any evidence that doing quantitative blood loss, quantitative assessment of postpartum bleeding is beneficial. We have a little bit of evidence in the literature. So we have an institution that had sort of a before and after study where they adopted a quantitative approach to maternal blood loss. And they noticed when they did that, they were intervening earlier. They had a decrease in their median blood loss from both vaginal deliveries as well as cesarean deliveries. They were able to identify more hemorrhages early on and use more uterotonic agents. And by doing that, they were able to decrease the blood loss. So it does show that, developing some sort of quantitative approach is probably a good thing, and it will allow you to pick up people who are at risk of having more blood loss early on. Okay. So now we finally get into sort of the response. The response that's normally put out is sort of a stage-based obstetric hemorrhage response, where you can rely potentially on algorithms, a sequence of first-line and second-line medications, checklists, and then if you do get into a patient who has a massive transfusion, having a protocol that you can rely on for mobilizing those resources and understanding how to transfuse that patient most effectively. In addition, having a plan for support for patients that have large morbidity but survive, families of those patients and staff that go through these really emergent events, and then partnering with blood bank to get a timely request for those products should be part of the massive transfusion protocol. You want to involve your blood bank resource in developing those protocols so they can help determine what is going to work best at that institution. So this is just a general overview where we usually stage obstetric hemorrhage by the amount that we've estimated or tried to quantify. So stage 1 is once you clear 500 milliliters from a vaginal delivery or 1 liter from a cesarean delivery. And stage 2 is after they go over a liter and you're approaching 1.5 liters. And once it clears 1.5 liters for either type of delivery, you begin to work to stage 3. So here's an example of how you might want to lay out those stages, right? And you can see sort of the procedures, what's done at the blood bank. So ideally, we talked about implementing quantitative blood loss, managing the 3rd stage after the placenta is delivered with standard oxytocin dosing, determining risk factors as the postpartum period begins. And then as you notice a higher amount of bleeding, notifying more appropriate people, increasing the frequency of the vital signs, getting better intravenous access, right? Implementing measures to, if it's uterine atony, which it often is, to try to get the uterine tone to be improved, right? And then maybe early on, think about getting matched blood available if it's possible. And then we move into the next stage, stage 2. So now you're mobilizing more people. You're trying to evaluate the cause of the bleeding, maybe sending some laboratory studies to help you with that decision process. Now you're starting with, second-line agents in addition to the oxytocin, so methergin, carbapenem, misoprostol, maybe getting larger access, thinking about additional medications that we'll talk about like tranexamic acid or fibrinogen concentrate, and then deciding, not only notifying the blood bank, but deciding if you need to move, say, to the operating room or a different location. And then finally, in the 3rd stage, now things are quite critical at this point. So you're activating that massive transfusion protocol. Ideally, if resources are available to you, you're beginning to transfuse during this emergent portion where there's often significant bleeding rapidly in sort of a fixed ratios, say 1 unit of packed cells to 1 unit of fresh frozen plasma. And then every time you get around 4 or 5 of those paired units in, if you have platelets available, giving those platelets, right? And if you're at a location where you don't have these kind of resources available and you're in this stage, thinking about packaging that patient up and trying to transport them to a healthcare location where they do have the resources that are available, right? And they are also thinking about different procedural techniques, uterine sutures, intrauterine balloons. Are you going to ultimately need to do some sort of hysterectomy? And then sending off labs as you can, but often in this stage, the bleeding is so rapid, your labs are more retrospective. And then assuming you eventually get the hemorrhage more under control, then you can transfuse to values that you're getting from your laboratory studies. But during sort of the heat of the moment, when this ongoing bleeding is occurring, the reason we use the fixed ratios are because you just don't have time to wait for those laboratory studies to get back to you to guide your transfusion. Oops. So, what evidence do we have for this? Well, not a tremendous amount, but other than the California experience I talked to you about, where we have a reduction, other institutions that have adopted these protocols, we seem to have a reduction. This is one publication that was out there in 2014 when they adopted a comprehensive maternal hemorrhage protocol. And what they showed was they actually identified more hemorrhages that were occurring than they had before the implementation of the protocol. But once they implemented it, when they did get a hemorrhage, overall, by using these fixed ratios and earlier transfusion, they actually used less blood products than they had before they had these protocols in place. So I just want to take a moment and go over some of the uterine tonics. I know we have a mixed audience, and so I'm not always sure how familiar these drugs are to everybody. So let's just take a minute or two and do this. So the primary first-line agent for preventing postpartum hemorrhage from uterinectomy is oxytocin, right? The WHO recommends that everybody gets 10 units after delivery, but sometimes more units are used. Ideally, you'd like to give it over time. It can be bolused, but you want to bolus in very small amounts, just a couple units at a time. Bolus administration can cause hypotension and vasodilation. It can also cause some nausea and vomiting too. If you don't have ability to place it intravenously, it can also 10 units can be given intramuscularly as an alternative. Second line agent, methergin, methylergonavine, 0.2 milligrams is given intramuscularly. It causes a generalized vasoconstriction in addition to working on the smooth muscle of the uterus and tightening it up. Secondary effects, it can also cause nausea and vomiting. In rare patients that have pulmonary hypertension, you don't want to use it. It can increase the pulmonary artery pressures. Patients who have a history of coronary vasospasm, which is incredibly rare in this population of patients, as they're usually younger women, but if for some reason they had that history, you wouldn't want to use this drug. Or patients that are preeclamptics with significant blood pressure increases or chronic hypertensives, you don't want to use this drug because it can rapidly increase their blood pressure and potentially have the risk of increasing their chance of stroke. So relative contraindications are hypertension, preeclampsia, and ischemic heart disease for this drug. The next drug that's also a second-line agent is carboprost. It's also known as 15-methylprostaglandin F2 alpha. It is also only given intramuscularly, 0.25 milligrams. It can be repeated about every 20 minutes. It also causes some nausea, vomiting, diarrhea. You want to avoid this in anyone who has asthma. It has a high propensity to cause bronchospasm. It will also increase pulmonary artery pressure, so should be avoided in women with pulmonary hypertension, or if they already have hypoxemia, you would be worried about it exacerbating that with the bronchospasm. You don't want to give this intravenously. It should only be given intramuscularly. And then another second line agent is misoprostol, also known as prostaglandin E1. Typical doses, it comes in a tablet, are 400 to 800 micrograms. It just needs to be placed on a mucosal surface. So it can be given orally, vaginally, rectally, or sublingually. It can also be swallowed. Its main side effect is it can increase core temperature. Now, normally, this drug will only increase core temperature to around 38 degrees. So you're still able to identify higher fevers that might be due to chorioamnionitis, but it will increase that. The nice thing is that it doesn't seem to affect blood pressure and it doesn't cause bronchospasm. So an example would be, let's say you had a woman who was a preeclamptic with high blood pressures and she had asthma and your oxytocin wasn't working, right? You're not really going to be able to use your methergin. You're not going to be able to use your carbaprost. And so this is the agent you're left with because it doesn't have those side effects of the other two. All right. Now, what does the WHO recommend? So they updated those original 2012 guidelines in 2018 and 2020. And what we see here is the first thing they said is they want, as a prophylactic agent, all postpartum women to get 10 international units of oxytocin, right? And ideally, they would like it to be given intravenously if possible, slowly, over about 20 minutes, 10-20 minutes, so that you don't have that hypotension. But they developed an algorithm here. So again, are skilled healthcare people available? And do you have the uterotonics? If it's yes, is oxytocin available? Do you have sufficient quantities? If all those things are in place, then you want to proceed with the oxytocin. But if you don't have skilled healthcare professionals who could administer the oxytocin, then their recommendation is for misoprostol, right? 400 micrograms or 600 micrograms orally. If oxytocin is not available, but you do have skilled professionals who can give intravenous or intramuscular medications, there's another medication, which is an analog of oxytocin called carbetocin, and that could be given as an alternative. Also, you could have your ergotamines or methyl ergotamines, 200 micrograms like we talked about. So using it as a first line agent instead of a second line agent. They do make fixed combination agents of oxytocin and ergotamines that could be given, or if none of those are available, you could go back and fall back on the misoprostol. So just the idea that there are a variety of items there to improve uterine tone, but if possible to administer intravenous oxytocin in an infusion over time, that's probably the best way to go based on the evidence. Okay. So in addition to uterotonics or medical strategies, what about procedural strategies? Okay, so this was a paper, it's probably 15 years old now, but just the idea that there's a variety of procedural strategies. So we're going to talk a little bit, or at least I'll show you pictures of what B Lynch or compression sutures look like for the uterus for women who've had C-sections. We know about arterial embolization, where they need to go to an interventional radiology suite and could have the bleeding embolized if it's available. And again, you could do surgical techniques where you ligate some of the arteries feeding the uterus. And then there's also the uterine balloon that's inserted in the uterus, either vaginally or during a C-section directly, that can help tamponade. Interestingly, no specific procedure has been shown to be better than the others, The idea is just having whatever you can available based on your resources. Okay, so this is an example on the left of an intrauterine balloon. So it's inserted deflated into the uterus, and then it's filled, right, with fluid, and it tamponades the wall of the uterus from its pressure. You can see a catheter going up through the middle of the balloon so that you can still monitor bleeding behind the balloon and see if the woman is still actively hemorrhaging despite the presence of the balloon, right? The other thing it allows you to do is once the hemorrhage has, ideally stopped from the balloon, rather than just taking it out, you can just deflate it and see if the pressure needs to be replaced again and reinflate the balloon, or if the bleeding has genuinely stopped. So it's sort of a test also, once it's in place, that you can use to see if hemorrhage has stopped. It can also be used to temporize measures if you need to transport the woman to another healthcare facility that has better resources. Here we have an example on the right side of the slide of compression sutures. So these are a large, say, O-silk suture that is used through surgical placement to compress or tamponade the uterus, as well as the original incision from the cesarean delivery, rather. And so that's a resource that is very inexpensive. But on the flip side, it takes a large amount of surgical skill to put it in place. You need an obstetrician or a surgeon who's able to do it. Cost is very cheap. Cost of the intrauterine balloons, when I looked about a year ago, at least in the United States, they were about $150, which, is expensive, but yet relative to other things is reasonably priced, so that it is possible to get a few on your unit, so they are available. Okay, the WHO in 2021 does have a recommendation of using the uterine balloon for the treatment of postpartum hemorrhage. Okay, and this is their statement that is recommended for treatment of postpartum hemorrhage due to uterine atony after vaginal birth in women who do not respond to standard first-line treatment, providing the following criteria are met, right? And so you can see there's sort of immediate recourse to surgical intervention and access to blood products if needed, right? So you have that. And then first-line treatment with medications. You're ruling out other causes of postpartum hemorrhage like retained products or trauma, right? Like a uterine rupture. And then the procedure obviously has to be performed by someone who knows how to do it and has been trained to do it. But, the training is something that can occur relatively easily after just seeing a few done or doing a few, people become skilled at it. And that you continue to monitor the patient even though the balloon's in place. Okay. What are some other measures to temporize massive hemorrhage? So again, they're not going to fix it, but they may buy you time while you're trying to get blood or get medications administered or so on. So putting the patient in Trendelenburg positioning, using vasopressors just to temporize, say like phenylephrine or ephedrine, or in some cases epinephrine if things are going really bad, raising the patient's legs to get more blood to the core, having the surgical team apply pressure to bleeding areas if you're in a cesarean delivery, or if it's some sort of vaginal laceration, applying pressure to that. And then I've only been in this situation once, but occasionally needing the surgical team to compress the aorta, right? Because you just need to buy time to try to catch up with fluids or medications or procedures, right? So we're going to talk a little about external aortic compression in a moment, but these are the WHO's recommendations in addition to those. So we'll talk about external aortic compression, bimanual uterine compression for cesarean deliveries or uterine compression in general for vaginal deliveries. Anti-shock garments can temporize. it is not recommended to uterine pack because in general, it will just hide the hemorrhage and it doesn't really tamponade. You really need a uterine balloon. Okay, so external aortic compression. Hopefully a very rare event that you may not be seeing much in your career, but every now and then, just know that it is something that can be done. You can look up this article for a little bit of better idea how to do it. But externally, it's really just taking your fist and pushing down and compressing the aorta against the spine or the vertebral column. And then at the same time, using your other hand to check femoral artery pulsations, because if you're tamponading the aorta effectively, you should lose those pulsations to the legs while you're doing it. And so that's your measure of, are you effectively compressing the aorta? This can also be done sort of internally if you're in the middle of a cesarean delivery. That's where I have seen it used once on one of my cases. Where the surgeon, in order to just temporize the bleeding, can take their fist and visibly compress the aorta against the lumbar curvature of the spine prior to the takeoffs of the uterine arteries. And again, it's not going to fix the bleeding, but it will allow you to catch up with your transfusion and maybe get additional people there and so on. Okay. Another way of doing internal manual compression is to exteriorize the uterus so that you can have a better view of what's going on. And then again, taking their dominant hand within the abdomen and compressing the aorta against the vertebral bodies. Now, we have just a tiny bit of evidence in the literature about the efficacy of this other than case reports. This one out of Egypt, where after they added this to their maternal hemorrhage protocol as something to be done, they happened to see a reduction in their deaths from postpartum hemorrhage. Okay, so a couple more interventions, medical interventions now for treatment. First thing I want you to think about is fibrinogen. So obstetric hemorrhage really can deplete coagulation factors and specifically fibrinogen. We have good evidence that low fibrinogen in postpartum patients is associated with higher amounts of blood loss and needing transfusion, right? So these are the normal levels of fibrinogen in pregnancy. So you have a non-pregnant patient where there may be around the mid 300s or so. And then as the gestation continues, it is not uncommon at the time of delivery for fibrinogen levels to be 500 or above, right? So just know when you get your fibrinogen levels, if you get those labs, it's not normal for someone to be in the mid 300s. It means they probably are hemorrhaging and depleting their fibrinogen, okay? We have some evidence in the literature of the predictability of hemorrhage from fibrinogen levels, which sort of speaks to their importance, where this was a study where as soon as a woman began to have a postpartum hemorrhage, they immediately drew a fibrinogen level. And those with the lower levels of fibrinogen down below 200 were almost 100% guaranteed to have a severe hemorrhage, where as you got into higher levels, in general, the hemorrhage was often less severe. So you have an independent association with sort of starting fibrinogen levels at the just following birth and predictability of if you are likely, if your hemorrhage is to become severe or not. Okay. Another study, again, showing this idea with the mean fibrinogen concentration being associated with more hemorrhage. In general, fibrinogen levels lower than about 200 milligrams per deciliter within two hours of the diagnosis of hemorrhage had this independent association with the hemorrhage becoming severe. Okay, so we have this association. So the question then is, well, when should we treat it? Right? And there's still a lot of debate. I will say that at least in the United States, most people for postpartum hemorrhage, if they get a fibrinogen level below 200, they will often treat with some sort of product. Now, we have a variety of products that contain fibrinogen. Some are more readily available at certain institutions than others, but we have fresh frozen plasma, which has somewhere between 1 to 3 grams per liter, usually comes in about a 250 mil. Because again, another thing to think about of this is when you have a massive transfusion going on, you're not only thinking about red cells, you're thinking about volume, and you're also thinking about coagulopathy, right? So that's maybe also how you're choosing things. So one nice thing about FFP is it does provide a little bit of volume. If available, cryoprecipitate can give you a tremendous amount of fibrinogen. It's worth usually about the fibrinogen of 10 FFP units or fresh frozen plasma units, right? And its volume is around a little under half a liter. It is a huge resource though, because to create it, you've used 10 units of FFP in order to create 1 unit of cryoprecipitate. And then finally, we have a fibrinogen concentrate, which has to be reconstituted. It usually takes 15 or 20 minutes, but that can be short compared to melting fresh frozen plasma. That's 20 grams per liter, comes in a small amount, so it won't help you with the volume problem, but it can get you fibrinogen fast. And so that's another resource that often healthcare institutions that don't have fresh frozen plasma or cryoprecipitate readily available will have fibrinogen concentrate available instead. Okay. Again, like I said, we don't really know exactly what level to treat at, but usually below 200 is what we do. We're still looking for more research to determine optimal fibrinogen levels. When should we really treat? But the bottom line, the take-home message is fibrinogen should be much higher at the time of delivery. And we have associations that once it gets low, you're more likely to have a severe hemorrhage. Okay. That brings us to another medical intervention, tranexamic acid or TXA. It is an inhibitor of fibrinolysis. And so it doesn't form clot, but it prevents clot from being broken down and has been shown to likely reduce bleeding in the setting of some coagulation abnormalities. So in 2017, there was a very large trial published in Lancet. It included over 20,000 women with postpartum hemorrhage. It included both low and high resources countries. And what it did was that when the hemorrhage occurred, the women received 1 gram of TXA or a placebo. And what they noticed was in the women that were in the TXA group, they had a significant reduction in mortality from hemorrhage compared to the group that just got the placebo. The key though is it needs to be given early, certainly within 3 hours of diagnosing the postpartum hemorrhage. Okay. And how do you give it? You give it as a gram over 10 minutes. And then if 30 minutes later, the hemorrhage is still going on, you give another gram. Okay. The other nice thing about this large trial with 20,000 women was we saw no difference in thromboembolic events between the groups, seizures, or kidney complications. If you give high doses of TXA, much higher than is talked about here, one of the side effects is seizure. So that's why they were looking for that. Okay. So kind of like, where does it fit in the protocol? I don't know that it's completely the primary treatment for postpartum hemorrhage. You need the other uterotonics. You need, things, resources for transfusion and personnel. But once the woman starts to have a hemorrhage, it normally should be administered. It works a lot better early on. It seems to be incredibly safe from that trial that I quoted. And so we routinely use it. Once we diagnose postpartum hemorrhage, we give a gram of TXA over 10 minutes. Okay. The WHO has adopted it in 2017 following that trial into their recommendations. And again, they make the general statement, early use of intravenous TXA within 3 hours, in addition to the standard care, is recommended for women diagnosed with postpartum hemorrhage following either a vaginal birth or a cesarean delivery. Now, one of the things that have been looked at is there was another large trial that had 11,000 women in it that they just finished data collection on for could it be given prophylactically for cesarean delivery. So that means all cesarean delivery, should we just give it? And the evidence in that trial, which was just put out in an abstract earlier this year, was that it did not reduce blood loss, but it did seem to reduce the need for second-line uterotonics, meaning methergin, carboprost, misoprostol, things like that. So there has not been an official statement made following a rigorous peer review process about whether any of this would be adopted prophylactically. So currently, it's only recommended after a postpartum hemorrhage is diagnosed. Okay. And then finally, last couple of slides are reporting. So anytime you have a big postpartum hemorrhage and it's done, even though everyone's usually exhausted and somewhat traumatized themselves, it is an incredible opportunity to learn what can be done better. And so you really want to establish this culture of debriefs where everybody gets together while events are still fresh in their mind and can talk about what resources weren't available, what things can be improved within that institution, and have it reviewed both at that time and also later on formally by a committee where you have representation from all the disciplines. Okay. This is just an example of a debrief form, and it just adds some structure to that discussion. There's a whole variety of them in some of the resources that I gave you earlier. So with that, I think I left just under 10 minutes for some questions and discussion. And so now I'm going to open up the QA session and see, what maybe I already answered and what I haven't. So first question we have is, do you agree that underutilization of diagnostic imaging as a reason for not knowing the cause of PPH, such as cervical varices using ultrasound? So the first thing I would say is diagnostic imaging, I think is good. I would say usually if you're in the middle of a postpartum hemorrhage, what you really like is interventional radiology, which I think is maybe what you mean also. And therefore, you can not only diagnose it, but you can simultaneously treat it with embolization. And it's an incredibly effective tool. Now, having said that, it is a tool that is not available at many, many healthcare places, especially in low resource countries. And even in the US, the majority of our births in the US, which is a very high resource country, still occur at small hospitals across our country where they have less than 500 births a year. So I'll say that again, even in the US, the majority of births that occur in our country occur in small hospitals where they have less than 500 births a year. And at those hospitals, they do not have interventional radiology or ability to diagnose with imaging. So if available, it's an incredibly effective tool, but the majority of locations are not going to have it available. And so we have to have other plans too. Should there be a radiologist in the PPH working group? Absolutely. If they are available and you have those sort of resources at your institution, they should absolutely be part of it. It should be OBGYN, labor nurses, anesthesia, critical care physicians, emergency medicine physicians, blood bank personnel, radiologists, social workers, and so on. The more multidisciplinary you can make your group, the less likely that you are to miss something big that you would really like to implement. Okay. All right. Let's see. We got another question. Any protocol for advising sonography with patients with history of first or second trimester bleeding to detect cervical varices? I will tell you that's a little bit out of my area of expertise. I would want to defer to an OBGYN regarding, detection of cervical varices. Many of the high-risk areas of the world deliver babies where not all these items are available. Is there a modified list of necessary meds? Yeah, so I mean, the modified list is really the resource from the World Health Organization. They have put it out there. Basically, this is what you would really like to have, taking into account the high lack of resources in large regional parts of the world. And I would go to that resource first to try to figure out, all right, at a minimum, what would we really like to have? So look at those World Health Organization resources. And then if you're a more of a high resource area of the world, then you can, start to look at the others. I would still say, just from an educational perspective and developing protocols and simulation and thinking about putting things together, even though you don't have all the items, the other resources I put out regarding protocols are still useful. Remember, the idea with them are they're not something you just take as is. They are instructions on how to develop resources that are best fit your healthcare center, given likely the difference in resources between all these centers. Okay, now the chat. Oh, thanks for asking. Thank you. Let's see. I have a few more minutes. Are there any more questions? All right. It doesn't look like it. So again, thank you so much for your attention. I feel really privileged to have the opportunity to give this presentation, and good luck.
Awesome. Thank you so much, Dr. Rollins. This was a very informative presentation. I think it's a very common topic. Like you said, the prevalence is there. And so it's very nice to go through the guidelines and see what the literature says and what we can apply to the institutions that everyone's from. So it was a pleasure to have you. Thank you so much for giving us your time, expertise, and we can't wait for you to come back. And thank you everyone else for joining as well.
All right. Have a good day.
All right. Take care. Bye, everyone.